The emergency room at St. Michael's Hospital erupted into chaos at 3:17 in the morning when the ambulance doors burst open and paramedics rushed in, wheeling a gurney carrying a man in his mid-30s, convulsing violently under the harsh fluorescent lights. Dr. Marcus Chen stood near the nurse's station, his fingers tapping rhythmically against his thigh in sets of 3, a self-soothing pattern he'd developed since childhood to manage the overwhelming sensory assault of the ER. The sirens, the shouting, the smell of antiseptic mixed with blood and fear, it all crashed against his heightened senses like waves against rocks. But Marcus didn't flinch. He never did when a life hung in the balance. His dark eyes locked onto the patient with laser focus, his mind already cataloguing symptoms, calculating probabilities, running through differential diagnoses at a speed that left his colleagues bewildered. The head nurse, Patricia, called out vital signs as the trauma team surrounded the gurney, but Marcus was already moving, his white coat billowing behind him as he approached with purposeful strides that seemed almost choreographed in their precision. The patient, identified as Robert Callahan, 42 years old, construction worker, had been found unconscious at a job site after complaining of severe abdominal pain. His face was pale, almost grey, coated in a sheen of cold sweat that caught the overhead lights. His breathing came in, shallow, rapid gasps, and his abdomen was visibly distended, rigid as a board beneath the thin hospital blanket. Dr. Sarah Mitchell, the senior attending and Marcus's supervisor, barked orders with military efficiency, demanding blood work, imaging, and IV fluids immediately. She was a formidable woman in her 50s, with silver-streaked hair, pulled back in a severe bun, and eyes that could cut through incompetence like a scalpel through tissue. She'd made no secret of her skepticism about Marcus's abilities, often questioning his unorthodox diagnostic methods and his tendency to fixate on obscure details that others dismissed as irrelevant. Tonight would be no different. Marcus stood at the foot of the gurney, his eyes tracking every tremor, every twitch, every subtle change in the patient's presentation, while his mind assembled the puzzle pieces with the speed and precision of a supercomputer. Acute abdomen, likely appendicitis, Dr. Mitchell announced with confidence, her voice cutting through the controlled chaos. Get him to imaging now. We need a CT scan to confirm before we take him to surgery. The team moved with practiced efficiency, but Marcus remained still, his gaze fixed on something the others had missed. His fingers had stopped their rhythmic tapping. In the sudden stillness of his body, there was an intensity that made the air around him seem to thicken. He noticed the slight yellowish tinge to the patient's sclera, the faint bruising pattern on the left flank that didn't match the typical presentation of acute appendicitis, the way the patient's right hand clutched at his left side rather than the right lower quadrant where appendicitis pain typically localized. These details assembled themselves in Marcus's mind like pieces of a three-dimensional puzzle, forming a picture that contradicted the obvious diagnosis. But he hesitated. He always hesitated in these moments, not from uncertainty about the medicine. He was rarely uncertain about that, but from the social calculation of when to speak, how to phrase his observations, so they wouldn't be dismissed as the obsessive fixations of someone who couldn't see the forest for the trees. Dr. Mitchell, Marcus said, his voice quiet but firm, cutting through the noise with unexpected authority. The senior attending turned toward him, her expression already showing signs of impatience. Marcus could read the micro-expressions that flickered across her face, the slight narrowing of her eyes, the tightening of her jaw, the subtle shift in her posture that signaled she was preparing to dismiss whatever he was about to say. He'd seen these signs hundreds of times before, from teachers, colleagues, even family members who couldn't understand how his mind worked, who mistook his different perspective for deficiency rather than depth. I don't think this is appendicitis, Marcus continued, his words measured and careful. The bruising pattern on his left flank, the jaundice, the way he's guarding his left side rather than his right, these signs suggest something else, something more serious. Dr. Mitchell's expression hardened into stone. Around them, the ER seemed to hold its breath. Nurses paused in their tasks. A resident standing nearby looked between Marcus and Mitchell like a spectator at a tennis match. The attending attending physician crossed her arms over her chest, a defensive posture that Marcus recognized as a prelude to confrontation. "Dr. Chen," she said, her voice dripping with barely concealed condescension, "I understand you have your theories, but we don't have time for academic exercises right now. This patient is critical. The presentation is textbook acute appendicitis, fever, elevated white blood cell count, abdominal rigidity, and acute pain onset. We follow standard protocols here, not hunches." Her words landed like slaps, each one designed to put him in his place, to remind him of the hierarchy that governed hospital medicine, to reinforce the unspoken rule that his different way of seeing should stay silent unless it aligned with conventional wisdom. Marcus felt the familiar tightness in his chest, the sensation of his throat constricting, the overwhelming urge to retreat into himself and let someone else handle the confrontation. Social conflict was his kryptonite, the one arena where his exceptional abilities offered no advantage. But beneath that, discomfort, beneath the anxiety that made his hands want to resume their rhythmic tapping, there was something stronger, the absolute certainty that he was right, and that certainty meant a life hung in the balance. He met Dr. Mitchell's gaze and held it, something that required every ounce of his will. The standoff between Marcus and Dr. Mitchell stretched for what felt like an eternity, but lasted only seconds, the kind of charged silence that made everyone in the immediate vicinity acutely aware they were witnessing something significant. Marcus's mind raced through the decision tree: push harder and risk professional consequences, or step back and let standard protocol proceed, even though every instinct screamed that something crucial was being missed. His fingers began their tapping pattern again, 3 beats against his thigh, a physical manifestation of the internal processing that never stopped, the constant analysis and recalibration that defined how his brain navigated the world. The patient groaned, a low sound of agony that cut through Marcus's deliberation like a knife through silk. Robert Callahan's face had gone from grey to nearly translucent, his lips taking on a bluish tinge that signaled deteriorating oxygenation. Time was running out, and Marcus knew with crystalline certainty that sending this man to CT and then to surgery for an appendectomy would be a catastrophic mistake, one that would likely cost Robert his life before. The surgeons realized their error. "His blood pressure is dropping," one of the nurses called out, her voice tight with concern. 90 over 50 and falling. Patricia, the head nurse who'd worked with Marcus long enough to recognize when he was onto something, shot him a look that contained both question and encouragement. She'd seen him pull off diagnostic miracles before, those moments when his unique way of processing information cut through conventional wisdom to find the truth. Hiding in plain sight, Dr. Mitchell barked orders for vasopressors to support the patient's blood pressure, her focus entirely on stabilization rather than underlying cause. Marcus watched her work with a mixture of respect for her technical skill and frustration at her rigid adherence to the obvious diagnosis. He understood why she thought the way she did. Appendicitis was common. It fit most of the symptoms, and Occam's razor suggested that when you hear hoofbeats, you should think horses, not zebras. But Marcus had long ago learned that sometimes the hoofbeats really did belong to zebras, and the cost of assuming otherwise could be measured in human lives. "Dr. Mitchell, please," Marcus said, stepping closer to the gurney, his voice gaining strength from desperation rather than confidence. "Just look at the bruising pattern. It's Cullen's sign, periumbilical ecchymosis, and the flank bruising is Gray Turner's sign, combined with the jaundice and the left-sided pain. This points to acute necrotizing pancreatitis, possibly hemorrhagic. If we operate thinking it's appendicitis, we won't be prepared for what we find, and by the time we realize the mistake, he'll be in hypovolemic shock from internal bleeding we can't control fast enough." The words tumbled out faster than Marcus usually allowed himself to speak, his careful social modulation breaking down under the urgency of the moment. He was aware of how he must look, intense, almost manic, his hands moving in that repetitive pattern, his gaze fixed with an intensity that others found unsettling. He was aware that he was breaking unspoken social rules about deference to authority, about tone and presentation, about all the subtle ways communication was supposed to happen that had never come naturally to him. But none of that mattered, as much as the fact that Robert Callahan was dying, and Marcus could see exactly why, even if no one else would listen. Dr. Mitchell's expression shifted through several emotions in rapid succession. Surprise at Marcus's forceful presentation, irritation at being contradicted in front of the team, and then something more complex, a flicker of uncertainty that suggested his words had penetrated her initial dismissal. She looked down at the patient with fresh eyes, really studying the details Marcus had pointed out. The bruising was there, subtle but present once you knew to look for it. The jaundice was mild, but unmistakable. The pain location was indeed atypical for appendicitis. For a moment Marcus thought he'd broken through, that she would reconsider, order different imaging, adjust the treatment plan. Then her face hardened again, professional pride reasserting itself like armor against doubt. "I've been practicing emergency medicine for 23 years, Dr. Chen," she said, her voice cold enough to freeze water. "I've seen thousands of acute abdomens. This patient needs surgery, and he needs it now. Your speculation about rare complications is noted, but we don't have the luxury of pursuing every unlikely possibility when a patient is this unstable. Now step aside and let us do our jobs." The dismissal was absolute, final, delivered with the weight of experience and authority that Marcus couldn't match. He felt the familiar sensation of walls closing in, the social defeat that always accompanied these moments when his different perspective clashed with conventional wisdom and lost. Around him, the ER continued its dance of organized chaos, nurses adjusting IV lines, residents documenting everything on electronic tablets, technicians preparing to transport the patient to imaging. Marcus stood frozen at the periphery, his mind screaming that they were making a fatal mistake, but his voice trapped by the social calculus that told him he'd already overstepped, already marked himself as difficult, already burned whatever credibility his previous successes had earned him. Patricia caught his eye again, her expression sympathetic but helpless. She'd advocated for him before and paid the price in Dr. Mitchell's cold treatment afterward. The system wasn't designed for people like Marcus, people who saw patterns others missed but couldn't always explain them in ways that fit the expected frameworks of communication and hierarchy. It was designed for smooth efficiency, for clear chains of command, for decisions made by senior physicians and executed by everyone else without question. And right now, that system was about to kill Robert Callahan. They wheeled Robert Callahan toward the CT scanner, his gurney surrounded by the trauma team like a presidential motorcade, monitors beeping their warnings into the antiseptic air of the hospital corridor. Marcus followed at a distance, not officially part of the team moving forward with the case, but unable to walk away, drawn by the same compulsion that made him solve puzzles until they surrendered their secrets. His mind wouldn't release the diagnostic thread he'd identified, couldn't stop running through the implications of what he believed was happening inside Robert's abdomen. Necrotizing pancreatitis was a catastrophic condition, one where the pancreas essentially began digesting itself, releasing powerful enzymes that could liquefy surrounding tissue and trigger cascade failures throughout the body. The mortality rate was staggering, especially when diagnosis was delayed. If Marcus was right, and he was almost certain he was, then every minute spent pursuing the wrong diagnosis brought Robert closer to a point of no return where even perfect treatment couldn't save him. The hospital's fluorescent lights buzzed overhead, a sound that most people filtered out automatically, but that Marcus heard as a persistent electrical hum that set his teeth on edge. He'd learned to function despite sensory input that others never noticed. to push through the constant assault of sounds, lights, textures, and smells that his nervous system refused to downregulate. It was exhausting, like trying to think clearly while standing next to a jet engine. But he'd developed strategies over 3 decades of practice. The rhythmic finger tapping helped. Focusing intensely on a single problem helped. The medicine itself helped, giving his hyper-focused brain something worthy of its processing power, something where his different operating system became an advantage rather than a disability. But tonight, the sensory overload was worse than usual, amplified by stress and the knowledge that he was watching a preventable tragedy unfold in real time while being powerless to stop it. His hands trembled slightly as he walked, and he shoved them into the pockets of his white coat to hide the visible sign of his distress. In the CT scanning room, technicians positioned Robert on the table while Dr. Mitchell reviewed the scan parameters with the radiologist, a balding man in his 60s named Dr. Howard Pierce, who'd been reading images since before Marcus was born. They were setting up for an abdominal scan focused on the right lower quadrant, exactly what you'd order if you suspected appendicitis. Marcus hovered at the threshold of the control room, his status as junior physician keeping him physically separated from the decision-makers, but close enough to hear their conversation. "Classic presentation," Dr. Pierce was saying, nodding along as Dr. Mitchell described the case. "We'll see the inflamed appendix clear as day, probably with some periappendiceal fluid. Should be straightforward." Marcus bit his tongue hard enough to taste copper. Physical pain, to anchor himself against the overwhelming urge to interrupt again, to make one more desperate attempt to change their minds. But he'd already played that card and lost. Speaking up again would only cement his reputation as someone who couldn't function within the team framework, who let his obsessive tendencies override proper hierarchy and protocol. The scan took 8 minutes, each second stretching into eternity as Marcus watched through the window. Robert lay motionless on the table, sedated now to manage his pain, his body a landscape of failing systems that the people treating him didn't fully understand. When the images began populating the radiologist's screens, Marcus moved closer, his eyes scanning the cross-sectional slices of Robert's abdomen with the intensity of someone reading a foreign language that only they could translate. And there it was, clear as daylight to anyone who knew what to look for. The pancreas was enlarged and edematous, with areas of decreased enhancement suggesting tissue necrosis. There was fluid in the lesser sac, tracking down into the pelvis. The appendix, meanwhile, looked completely normal, a small tubular structure showing no signs of inflammation or perforation. Marcus's breath caught in his throat. The evidence was irrefutable, displayed in shades of grey on the high-resolution monitors, a definitive answer to the diagnostic question that Dr. Mitchell had already decided in her mind before looking at any imaging. "There," Dr. Mitchell said, pointing at the screen, her finger indicating a small area near the cecum. "You can see the appendiceal wall thickening right there. It's subtle, but it's definitely inflamed." Marcus blinked, confusion momentarily overriding his social anxiety. He leaned closer to the monitor, studying the area she'd indicated. There was no wall thickening. The structure she was pointing at was a normal fold of bowel, a shadow artifact that could look suspicious if you were determined to see pathology there. Dr. Pierce frowned, adjusting the image contrast and zooming in. He said, his tone uncertain. "I'm not sure I'm seeing what you're seeing, Sarah. The appendix looks pretty unremarkable to me, but this here," he pointed at the pancreas, "this is concerning. Significant inflammation, possible necrosis. We should be thinking about pancreatitis, probably severe given the extent of involvement." Marcus felt a surge of vindication so strong it almost made him dizzy. The radiologist saw it. The evidence was there. They would change course now, adjust the treatment plan, give Robert the intervention he actually needed rather than cutting into his abdomen for an organ that wasn't diseased. Dr. Mitchell stared at the screen in silence, her jaw working as she processed Dr. Pierce's interpretation. Marcus could see the war happening behind her eyes, professional pride clashing with medical reality, the human difficulty of admitting error, battling against the physician's duty to the patient. The moment stretched, crystallizing into one of those pivotal points where a single decision branches into vastly different futures. Finally, Dr. Mitchell straightened her shoulders, her face settling into an expression Marcus had seen before, the look of someone choosing their narrative and committing to it regardless of contradicting evidence. "The pancreatitis is secondary," she said, her voice brooking no disagreement. "Appendicitis can trigger pancreatic inflammation through local spread and shared lymphatic drainage. We proceed with the appendectomy as planned. Once we remove the source of infection, the pancreatic inflammation will resolve." Dr. Pierce opened his mouth as if to object, then seemed to think better of it, his face settling into neutral professional courtesy. Marcus felt the floor drop out from under him. She was wrong, catastrophically, fatally wrong, and she was going to proceed anyway. The operating room hummed with quiet efficiency, a symphony of beeping monitors and hushed conversations between surgical nurses preparing for the emergency appendectomy. Marcus stood outside the OR suite, his forehead pressed against the cool glass of the observation window, watching the team position Robert Callahan on the surgical table. The patient was now under general anesthesia, completely vulnerable and dependent on the people surrounding him to make the right decisions, people who were about to cut into his abdomen, looking for a problem that didn't exist while ignoring the one that was killing him. Marcus's reflection stared back at him from the glass, ghost image superimposed over the scene inside, a 32-year-old man with dark, disheveled hair, shadows under his eyes from too many sleepless nights, and an expression of anguished helplessness that he rarely allowed anyone to see. He'd changed into surgical scrubs, but hadn't been invited to join the operation. Dr. Mitchell had made it clear that his presence wasn't required, a professional exclusion that stung more than it should have, because Marcus knew it wasn't really about the surgery. It was about punishment for questioning her judgment. Inside the OR, Dr. Mitchell stood at the surgical table, her hands raised and sterile, while a scrub nurse helped her into surgical gloves. The anesthesiologist, Dr. Ramon Santos, sat at the head of the table monitoring Robert's vital signs, adjusting flows of medications to keep him stable during the procedure. Two surgical residents flanked Dr. Mitchell, eager to assist and learn from the experienced surgeon. The scene looked like 100 other surgeries Marcus had observed during his medical training, professional, organized, following established protocols with practiced precision. Except this surgery was based on a misdiagnosis, and Marcus was watching from the outside, unable to intervene, like being trapped in a nightmare where you see disaster approaching, but your voice won't work and your legs won't move. His fingers resumed their tapping pattern against the glass. 3 beats, pause, 3 beats, pause, a metronome of anxiety and mounting dread. Dr. Mitchell made the first incision, a neat line in the right lower quadrant where the appendix would be easily accessible. Blood welled up along the cut, immediately suctioned away by the surgical assistant. The team worked with choreographed efficiency, deepening the incision through layers of fascia and muscle, separating tissue planes to reach the peritoneal cavity. "There's more free fluid here than I expected," one of the residents commented, his gloved hands holding a retractor to keep the incision open. "And it's not clear, looks a bit turbid, maybe early peritonitis." Dr. Mitchell nodded, her focus entirely on the surgical field. "Consistent with appendiceal perforation," she said. "Let's get in there and find it." But when they opened the peritoneum and got their first clear look at the abdominal cavity, the scene wasn't what they expected. There was indeed significant free fluid, but its appearance wasn't consistent with simple appendiceal rupture. It had a darker quality, streaked with what looked like old blood and tissue debris. The intestines were coated in a grayish exudate that suggested a more systemic inflammatory process. Marcus saw Dr. Mitchell's body language change, a subtle stiffening of her shoulders that signaled confusion. She explored the surgical field methodically, moving loops of bowel aside to get a clear view of the cecum and appendix. And there it was, the definitive answer. The appendix looked completely normal, pink and healthy, with no signs of inflammation or perforation. "That's unexpected," Dr. Mitchell said, her voice careful and controlled. Marcus pressed harder against the glass, his heart hammering in his chest. This was the moment of truth, the point where reality forced its way through preconceptions. But instead of immediately recognizing what was happening, Dr. Mitchell spent precious minutes examining the appendix from every angle, as if the inflammation might be hiding somewhere she hadn't looked yet, as if the organ would somehow reveal pathology if she just searched thoroughly enough. The seconds ticked by, turning into minutes, each one bringing Robert closer to the edge of survivability as the necrotizing pancreatitis continued its destructive rampage, unchecked. "Dr. Mitchell," Dr. Santos called from the head of the table, his voice tight with concern. "I'm seeing some troubling vitals here. Blood pressure is trending down despite pressors, heart rate is climbing, and his oxygen saturation is starting to drop. Something's not right." The anesthesiologist's warning finally seemed to break through Dr. Mitchell's fixation on the appendix. She straightened up, looking around the surgical field with fresh eyes, really seeing what was in front of her for the first time. The dark, necrotic-looking fluid, the greyish exudate on the intestinal surfaces, the generalized inflammatory response that extended far beyond what a simple appendicitis could cause. Marcus watched her face change as understanding began to dawn, the terrible realization that she'd been wrong, that someone had tried to tell her she was wrong, and that her pride and certainty had blinded her to the evidence. "We need to explore the left upper quadrant," she said suddenly, her voice sharp with urgency. "This isn't appendicitis. Dr. Chen was right, it's the pancreas." The admission hung in the air of the OR like smoke from an explosion. The surgical residents exchanged glances, uncertain how to respond to their attending physician, essentially announcing a major diagnostic error in the middle of an operation. Dr. Mitchell didn't wait for their processing, already moving to reposition her instruments and extend the incision. "We need to convert this to an exploratory laparotomy," she said, her hands moving with renewed purpose. "Get me better exposure, more retractors, and call for backup from general surgery. This patient is going into hemorrhagic shock, and we need to control whatever's bleeding before we lose him." Marcus felt a surge of relief so powerful it made his knees weak. She'd admitted the mistake. She was changing course. There might still be time to save Robert Callahan's life, but even as hope flickered to life in his chest, Marcus's medical knowledge reminded him of the grim statistics surrounding necrotizing pancreatitis, especially cases where diagnosis and treatment were significantly delayed. The mortality rate climbed with every hour that passed, and they'd lost precious hours chasing the wrong diagnosis, hours that Robert might not be able to afford. The operating room transformed from a routine appendectomy into a desperate battle for life, as Dr. Mitchell extended the incision into a full midline laparotomy, opening Robert Callahan's abdomen from sternum to pubis to get the exposure needed to address the catastrophic pancreatic crisis. The moment they properly visualized the pancreas and surrounding structures, the severity of the situation became undeniably clear. The organ was swollen to nearly twice its normal size, its surface mottled with areas of blackened necrotic tissue that looked like islands of death spreading across a dying landscape. Blood and pancreatic enzymes had leaked into the peritoneal cavity, creating a toxic soup that was chemically burning everything it touched. The lesser sac, normally a potential space behind the stomach, was filled with necrotic debris and hemorrhagic fluid. This wasn't just severe pancreatitis, it was hemorrhagic necrotizing pancreatitis, one of the most lethal conditions in acute surgical medicine, with mortality rates exceeding 50% even with perfect treatment. And this case had been anything but perfect. "Jesus Christ," one of the residents breathed, the curse slipping out despite the professional environment. Dr. Mitchell didn't reprimand him. The exclamation was entirely appropriate given what they were seeing, "Get 4 units of packed red blood cells up here, stat," she ordered, her voice taking on the clipped, urgent tone of someone managing a true surgical emergency. "Call in Dr. Harrison from General Surgery. Tell him we need his expertise immediately. And someone get Dr. Chen in here, now." The last order surprised everyone, including Marcus, who heard it through the intercom system that connected the observation area to the OR. A nurse appeared at his side moments later, gesturing urgently toward the surgical suite door. "Dr. Mitchell wants you scrubbed in," she said, already moving to help him with the sterile preparation process. Marcus's mind raced as he scrubbed his hands and forearms with the precise mechanical motion drilled into every medical student. 3 minutes minimum. Don't miss any surfaces. Keep your hands elevated above your elbows to prevent contaminated water from running down to sterile areas. As Marcus pushed through the OR doors, now properly gowned and gloved, he entered a scene of controlled chaos. Blood transfusion bags hung from IV poles, their dark red contents flowing into Robert's veins in a race to replace what was hemorrhaging into his abdominal cavity. Monitors screamed their alarms before being silenced by Dr. Santos, who was running multiple vasopressor medications at maximum doses, trying to maintain enough blood pressure to perfuse vital organs. The surgical field was a nightmare of inflamed tissue and bleeding vessels, the kind of operative scenario that appeared in medical textbooks as examples of worst-case complications. Dr. Mitchell looked up as Marcus approached the table, and in her eyes he saw something he'd never witnessed before: genuine respect mixed with a plea for help. "Dr. Chen," she said, her voice stripped of the condescension that had colored every previous interaction. "Between them, I need your input. You were right about the diagnosis. What else am I missing? What do I need to know about managing this?" The question represented a complete reversal of the hierarchy that had defined their relationship, a senior attending physician explicitly deferring to a junior doctor's expertise in front of the entire surgical team. Marcus felt the weight of the moment, the responsibility suddenly shifting onto his shoulders, the terrifying possibility that even being right about the diagnosis might not be enough to save this man's life. He stepped closer to the table, his eyes scanning the surgical field with the same intense focus he'd applied to the initial evaluation hours earlier. His brain shifted into that higher gear, where time seemed to slow down and irrelevant stimuli faded away, leaving only the problem and the pathways to potential solutions. "The hemorrhage is coming from the splenic artery," he said, his voice steady and clear, despite the chaos around him. "You can see the pulsatile bleeding right there at the pancreatic tail. The enzymatic digestion has eroded through the vessel wall. We need to ligate it immediately, or he'll exsanguinate before we can address anything else." Dr. Mitchell followed his pointed finger and saw what he'd identified, a rhythmic spurting of bright red arterial blood in sync with Robert's heartbeat, partially obscured by the pools of darker blood and necrotic material filling the operative field. "Suction here, more retraction," she commanded, her hands already moving with practiced efficiency to expose the bleeding vessel. "Get me vascular clamps." The next 15 minutes unfolded like a choreographed dance between death and salvation, with the surgical team working in absolute synchrony to control the hemorrhage before Robert's cardiovascular system collapsed entirely. Marcus stood at Dr. Mitchell's side, his role now that of expert consultant, pointing out anatomical landmarks that would normally be obvious but were obscured by the severe inflammation and tissue disruption. "Watch for the splenic vein there. It's fragile, and if it tears, we'll have venous bleeding on top of the arterial," he said. "And be careful around the pancreatic tail. There are areas of tissue that look solid but are actually just necrotic mush held together by inflammation. They'll disintegrate if you manipulate them too aggressively." Dr. Mitchell worked with the focused intensity of someone acutely aware that a patient's life hung in the balance of her technical skills, incorporating Marcus's guidance seamlessly into her surgical decisions. When they finally got clamps on the splenic artery and the pulsatile bleeding stopped, The entire team seemed to exhale collectively, a shared moment of relief that at least this one immediate crisis had been controlled. But controlling the bleeding was only the first step in managing hemorrhagic, necrotizing pancreatitis. The necrotic tissue itself presented an ongoing threat, a source of infection and systemic inflammation that could trigger multi-organ failure even if they stabilized the acute hemorrhage. Standard surgical wisdom suggested debriding the dead tissue, removing the blackened areas of pancreas that were beyond saving. But Marcus knew from his exhaustive reading of the medical literature that aggressive early debridement in necrotizing pancreatitis often made outcomes worse, disrupting tissue planes and causing more bleeding than it prevented. The current best practice was damage control. Establish hemostasis, place drains to evacuate the toxic fluid collections, and get the patient to intensive care where metabolic derangements could be corrected before any definitive procedures. "We shouldn't debride now," Marcus said, his words careful but firm. "The tissue planes are too inflamed and friable. Aggressive resection at this stage will cause more problems than it solves. We need to drain the collections, leave the necrotic areas alone for now, and get him stable in ICU. We can do staged necrosectomies later if he survives the initial inflammatory phase." Dr. Mitchell paused, her hands hovering over the surgical field as she processed Marcus's recommendation. Everything in her surgical training probably screamed to remove the dead tissue, to clean out the source of infection and inflammation. But she'd already paid the price for ignoring Marcus's insight once tonight. She wouldn't make that mistake again. "Okay," she said, nodding slowly. "We'll follow your recommendation. Let's place drains in the lesser sac and peripancreatic spaces, leave Penrose drains for continued evacuation, and get him closed up as quickly as safely possible." As the team worked to complete the damage control operation, Marcus felt the adrenaline that had been sustaining him begin to ebb, revealing the bone-deep exhaustion. Underneath, his hands trembled slightly as he held retractors in place, the physical manifestation of the emotional and mental toll of the past few hours. If you're still watching, drop a comment below and tell me, would you trust a doctor who sees what others miss, or does experience always trump instinct? Hit that like button and make sure you're subscribed, because Robert's fight is far from over, and what happens next will shock you. The intensive care unit at 3 in the morning had an eerie quality, a twilight zone between night and day where time seemed suspended and the usual hierarchy of hospital life relaxed into a more egalitarian exhaustion. Robert Callahan lay in bed 7, surrounded by enough monitoring equipment to run a small spacecraft, his body sedated and intubated while machines breathed for him and medications dripped into his veins at carefully calculated rates. His vital signs had stabilized somewhat after the surgery, but he remained critically ill, balanced on a knife's edge between recovery and decline. Marcus sat in a chair beside the bed, his white coat stained with blood and surgical fluids, his eyes red-rimmed from fatigue but still alert, still watching the monitors with the vigilance of someone who knew how quickly things could deteriorate. He'd been there for the past 4 hours, refusing to leave even though his shift had officially ended, driven by a combination of medical responsibility and something deeper, something harder to articulate, a need to see this case through, to know whether his diagnostic insight had come in time to make a difference, or whether Robert's delay in treatment would prove fatal despite their best efforts. Dr. Mitchell entered the ICU at 3:15, her surgical scrubs replaced by fresh ones, but her face showing the same exhaustion that Marcus felt. She'd spent the past hour in the surgical lounge filling out operative notes and consulting with the critical care team about Robert's post-operative management. When she saw Marcus sitting vigil at the bedside, she paused, her expression complex and difficult to read. Then she walked over, pulling up a second chair and sitting down beside him in a gesture that acknowledged something had fundamentally shifted in their professional relationship. They sat in silence for several minutes, watching Robert breathe with the assistance of the ventilator, watching his oxygen saturation numbers. Hold steady in the low 90s, watching the arterial line trace his blood pressure across the monitor screen in real-time waveforms. Finally, Dr. Mitchell spoke, her voice quiet enough that only Marcus could hear. "You were right," she said, "about everything. The diagnosis, the presentation, what we'd find in surgery. You saw it from the beginning and I dismissed you. I'm sorry." The apology hung in the air between them, unexpected and profound. Marcus had imagined this moment in various forms over the past few hours. Scenarios where Dr. Mitchell grudgingly acknowledged his contribution, or where she rationalized away her initial misdiagnosis, or where she simply never mentioned it at all, and they both pretended the conflict had never happened. But a direct, unqualified apology, that hadn't been on his list of likely outcomes. He turned to look at her, really look at her, and saw past the senior attending physician facade to the human being underneath. Someone who'd made a mistake, recognized it, and had the integrity to own it explicitly. "I should have listened to you from the start," Dr. Mitchell continued, her gaze still fixed on Robert's unconscious form. "I let my experience become arrogance, assumed that because I'd seen thousands of cases, I couldn't miss something important, and I let my preconceptions about you cloud my judgment. I've watched you work for 6 months now, Dr. Chen, and I've seen the patterns. You notice things others miss. You process information differently, and instead of recognizing that as a strength, I treated it like a liability, like something that needed to be managed or corrected." Marcus felt his throat tighten with emotion he hadn't expected to feel, a complex mixture of vindication and sadness and relief. "I'm used to not being heard," he said quietly, his fingers resuming their familiar tapping pattern against his thigh. "I've learned to expect that people will dismiss what I say because of how I say it, or because I can't always explain my reasoning in ways that make sense to others, or because my confidence doesn't match conventional social displays of authority. It's been that way my whole life. Teachers, colleagues, even family members who love me but don't really understand how my brain works." He paused, gathering his thoughts with the same careful precision he applied to differential diagnoses. "But in medicine, that disconnect has consequences, real consequences. When I see something and people won't listen, someone can die, like Robert almost did tonight." Dr. Mitchell nodded slowly, processing his words with what appeared to be genuine consideration. "How do you do it?" she asked. "How do you see the things that others miss? What's happening in your mind that's different?" The question was asked with authentic curiosity rather than clinical detachment, a genuine attempt to understand rather than categorize. Marcus considered how to explain something that was so fundamental to his experience that he'd never consciously broken it down. "It's like everything has the same volume," he finally said, using a metaphor that had helped him explain it to others in the past. "Most people's brains automatically filter out details that seem irrelevant, background noise, minor inconsistencies, small observations that don't fit the main narrative. Their perception naturally creates a hierarchy of importance based on expectations and experience. But my brain doesn't filter that way. Everything comes in at full intensity, all the details simultaneously, without automatic prioritization. It's overwhelming most of the time, honestly. But in medicine, it means I see the subtle signs that get filtered out of other people's processing, the slight discoloration that doesn't fit the working diagnosis, the pattern in lab values that suggests something unexpected, the detail that seems irrelevant until you realize it's the key that unlocks the entire puzzle. Dr. Mitchell listened with an intensity that matched Marcus's usual focus, absorbing his explanation like she was learning a new surgical technique. "That's actually remarkable," she said. "And exhausting, I imagine." Marcus gave a short laugh, dry and humorless. "You have no idea. The sensory overload alone is like trying to think clearly while standing in the middle of a rock concert. Every sound, every light, every texture and smell Well, it's all there, all the time, all demanding attention. And social interaction is its own special kind of torture because I'm constantly analyzing what people mean versus what they say, trying to decode expressions and tones and contexts that seem obvious to everyone else, but are like reading a foreign language for me. Medicine is actually one of the few areas where being this way is more advantage than disability, where my different operating system gives me capabilities that normal processing can't match. So yeah, it's exhausting, but it's also the only place I've ever really felt like my brain was doing what it was designed to do. They sat together in the quiet ICU, two physicians from very different perspectives finding unexpected common ground at the bedside of a patient who'd nearly died because their differences had prevented them from working together effectively. Robert's ventilator continued its rhythmic hissing, artificial breath flowing in and out of his lungs, while his body fought the massive inflammatory battle raging inside his abdomen. His prognosis remained uncertain. Hemorrhagic, necrotizing pancreatitis carried a brutal mortality rate even with perfect management, and the delayed diagnosis meant his body had sustained additional damage before treatment began. But he was alive, which he wouldn't have been if Marcus had accepted the social pressure to stay silent, if Dr. Mitchell hadn't ultimately found the humility to admit her error and change course, if the chain of events had broken at any of several critical points. Sometimes medicine came down to these razor-thin margins, these moments where one person's insight or one decision made the difference between life and death. "What happens now?" Marcus asked, gesturing toward the monitors and their constantly updating displays of Robert's physiological status. "What's his actual chance of survival?" Dr. Mitchell pulled up Robert's chart on the bedside computer, scrolling through the latest lab values and vital signs. "Honestly, maybe 50-50 at best. His lactate is still elevated, which means he's not perfusing tissues adequately despite all our interventions. His white blood cell count is through the roof, indicating massive systemic inflammation, and his platelet count is dropping, which suggests he might be developing DIC, disseminated intravascular coagulation, where his clotting system starts consuming itself. We've got him on broad-spectrum antibiotics to prevent infection of the necrotic tissue, pressors to maintain his blood pressure, the ventilator is doing most of his breathing work, and we're running continuous dialysis to help his kidneys handle the metabolic waste products. But ultimately, the next 48 hours will determine whether his body can mount enough of a recovery response to survive, or whether the inflammatory cascade will overwhelm him." Marcus absorbed the clinical assessment with the same thoroughness he applied to everything, his mind already running through potential complications and interventions. "If he develops infected necrosis, we'll need to go back for surgical debridement," he said, thinking out loud. "But the timing will be critical. Too early, and will cause more bleeding and tissue damage. Too late, and the infection will cause septic shock." Dr. Mitchell nodded. "We'll follow his clinical markers closely. Rising fever, increasing white count, worsening metabolic acidosis. Any of those could signal infected necrosis that needs intervention. There's also the possibility of developing pseudocysts, areas where the necrotic fluid walls off into pockets that can rupture or become infected themselves. This is going to be a marathon of management, not a sprint. Multiple procedures, extended ICU stay, months of recovery if he makes it through." The grim reality of Robert's situation settled over them like a weight. They'd saved his life in the OR, but the battle was far from over. Modern medicine had pulled him back from the immediate brink of death, but keeping him alive long enough to recover would require sustained vigilance, expert management, and more than a little luck. 48 hours after the emergency surgery, Robert Callahan's condition had stabilized into what the ICU team cautiously described as critically ill but improving. His vital signs had strengthened incrementally: blood pressure maintaining with lower doses of vasopressor support, lactate levels trending downward, suggesting better tissue perfusion, kidney function showing early signs of recovery. He remained intubated and sedated, his body needing the mechanical and pharmacological support to heal. But the trajectory was encouraging rather than catastrophic. Marcus had become a fixture in the ICU, returning between his other clinical duties to check on Robert's progress, to review the latest labs and imaging studies, to consult with the critical care team about adjustments to his management. Dr. Mitchell had made it clear that Marcus was now considered part of Robert's primary care team, his insights valued rather than dismissed, his different perspective treated as an asset rather than an aberration. The shift in their working relationship had rippled outward, affecting how other staff members interacted with Marcus, creating a subtle but noticeable change in the social dynamics that had always been his greatest professional challenge. On the morning of the third post-operative day, Robert's sedation was lightened to assess his neurological status, a standard procedure to ensure that the patient's brain was functioning properly and that they could potentially begin the weaning process from the ventilator. Marcus stood at the bedside alongside Dr. Mitchell and the critical care attending, Dr. Jennifer Huang, as they reduced the propofol infusion and waited for Robert to emerge from the medically induced unconsciousness. The process was gradual, starting with small movements, fingers twitching, facial muscles responding to stimulation, eyes moving beneath closed lids. Then Robert's eyes fluttered open, pupils constricting against the bright ICU lights, his gaze unfocused and confused, in the way of someone waking in an unknown place, with no memory of how they arrived there. The endotracheal tube prevented him from speaking, but his eyes tracked movement, following Dr. Huang as she leaned into his field of vision. "Robert, can you hear me?" she asked, speaking slowly and clearly. "I'm Dr. Huang. You're in the intensive care unit at St. Michael's Hospital. You had emergency surgery 3 days ago. You're safe and you're getting better." Robert's hand lifted slightly from the bed, a weak gesture that might have been an attempt to reach for the tube in his throat. Dr. Mitchell gently intercepted his hand, holding it in hers. "Don't fight the breathing tube," she said, her voice taking on a gentleness Marcus hadn't heard from her before. "I know it's uncomfortable, but it's helping you breathe while your body heals. If you understand me, can you squeeze my hand?" Robert's fingers tightened around Dr. Mitchell's, a clear response that indicated cognitive function was intact. Relief washed across the attending physician's face. Neurological complications from the severe physiological stress and the period of hemodynamic instability during surgery had been a real concern, and this simple hand squeeze suggested that Robert's brain had weathered the crisis without permanent damage. They ran through a series of simple commands: squeeze with left hand, move your toes, blink twice, and Robert complied with each one, demonstrating that his motor function and comprehension were both preserved. It was the best outcome they could have hoped for at this stage. Over the following hours, as Robert remained awake and more alert, the medical team prepared to attempt ventilator weaning, the process of gradually reducing the machine's support to allow his lungs to take over more of the breathing work. Marcus watched the respiratory therapist adjust the ventilator settings, decreasing the rate of mechanical breaths while monitoring Robert's oxygen saturation and respiratory effort. It was a delicate balance. Push too fast, and the patient's oxygen levels would drop dangerously. Move too slowly, and you prolonged their time on the ventilator unnecessarily, with all the attendant risks of ventilator-associated pneumonia and other complications. Robert tolerated the initial weaning trial well, his oxygen saturations remaining stable in the mid-90s, his spontaneous breathing efforts regular and adequate. By that evening, the critical care team made the decision to extubate him, removing the endotracheal tube and allowing him to breathe entirely on his own, with supplemental oxygen delivered through a face mask. The moment when the tube was pulled and Robert took his first independent breath in 3 days was surprisingly emotional, a milestone that marked a genuine turning point from critical illness toward recovery. "How do you feel?" Dr. Mitchell asked, once Robert had spent a few minutes adjusting to breathing on his own, his voice hoarse and painful from the trauma of intubation, but functional. Robert's answer came in a whisper, barely audible above the background noise of the ICU. "Like I got hit by a truck," he said, managing a weak smile despite the obvious pain. "What happened? I remember being at the job site, terrible pain in my stomach, and then nothing. Did I have appendicitis?" Dr. Mitchell exchanged a glance with Marcus, a silent communication that spoke of their shared experience with this case. "It wasn't appendicitis," she said carefully. "You had a very serious condition called necrotizing pancreatitis. Your pancreas became severely inflamed and parts of it died. You were bleeding internally, and you came very close to not making it. We had to do emergency surgery to control the bleeding and drain the infection. You've been in the ICU for 3 days. Robert's eyes widened, processing this information with the shock of someone realizing how close they'd come to death. "I almost died," he whispered. "Yes," Dr. Mitchell said simply, "but you didn't, and that's because of the doctor standing next to me." She gestured toward Marcus, who'd been standing slightly back from the bedside, his usual position at the periphery of social interactions. Robert's gaze shifted to Marcus, taking in the young physician with his rumpled white coat and tired eyes. "Dr. Marcus Chen here made the correct diagnosis when everyone else, including me, was looking in the wrong direction," Dr. Mitchell continued, her voice carrying a note of respect that made Marcus deeply uncomfortable with the attention. He recognized signs that others missed, fought to make his voice heard despite being told he was wrong, and ultimately saved your life by refusing to let us proceed with the incorrect treatment. You owe him a debt that can't really be repaid." Robert's hand extended toward Marcus, trembling from weakness but determined. "Thank you," he said, his voice breaking with emotion. "Thank you for not giving up on me." Marcus stepped forward and took Robert's hand, the physical contact less uncomfortable than it usually was, because the context made the social expectation clear and unambiguous. "I just did what any doctor should do," he said quietly. "I paid attention to what your body was telling us." The moment stretched between them, patient and physician, a connection formed through crisis and survival. Marcus felt something shift inside himself, a subtle recalibration of how he viewed his place in medicine and his role as a healer. He'd always approached medicine as an intellectual puzzle, a domain where his analytical abilities could shine and his social difficulties mattered less. But standing here, holding the hand of a man who'd nearly died, feeling the genuine gratitude and human connection flowing from that simple touch, Marcus realized that medicine was more than just diagnostic accuracy and clinical skill. It was about fighting for patients when systems failed them, about finding the courage to speak up when easier paths presented themselves, about the profound responsibility of holding someone's life in your hands and doing everything possible to preserve it. Robert Callahan wouldn't remember most of what had happened in the OR. He'd never know about the conflict between Marcus and Dr. Mitchell, about the diagnostic error or the dramatic reversal mid-surgery. But he would live, would eventually recover enough to return to his construction job and his family, and that outcome was built on a foundation of Marcus's refusal to stay silent, even when silence would have been socially easier. "You need to rest now," Dr. Huang said gently, interrupting the moment with practiced clinical authority. "Your body has been through tremendous trauma, and healing takes time and energy. We'll be right here, monitoring you constantly, adjusting your treatment as needed. You're not out of the woods yet, but you're heading in the right direction." Robert nodded, already looking exhausted. From the brief period of wakefulness and conversation, his eyes drifted closed, and within minutes, his breathing had settled into the regular rhythm of natural sleep, rather than sedated unconsciousness. Marcus, Dr. Mitchell, and Dr. Huang moved away from the bedside, gathering at the nurse's station to discuss ongoing management and potential complications. As they talked through the clinical details, drain outputs, antibiotic selection, nutritional support planning, Marcus felt the familiar comfort of medical problem-solving settle over him. This was his language, his domain, the place where his brain's different architecture became a superpower rather than a disability. And for the first time in his career, he was working with a senior colleague who genuinely respected that difference, rather than merely tolerating it. 2 weeks after his emergency surgery, Robert Callahan had progressed from critically ill to stable enough for transfer out of the intensive care unit to a regular medical floor. The journey hadn't been smooth. He'd developed a pseudocyst on post-operative day 7 that required percutaneous drainage, had fought a bout of ventilator-associated pneumonia that set his recovery back by several days, and experienced the kind of generalized weakness and debility that came from surviving a catastrophic illness. But he was alive, increasingly alert, able to eat small amounts of food, and most importantly, his pancreas was showing signs of healing rather than ongoing necrosis. Marcus had followed his case throughout the hospitalization, checking in daily, adjusting management in consultation with the primary team, becoming something of a familiar presence in Robert's recovery narrative. The patient had asked about him repeatedly, wanting to thank the doctor who'd saved his life, wanting to understand more about what had happened during those critical hours when his fate hung in the balance. On a sunny Thursday afternoon, Marcus sat in a chair beside Robert's hospital bed, the patient now strong enough to hold extended conversations and coherent enough to process the full story of his medical crisis. Robert's wife, Jennifer, sat on the other side of the bed, holding her husband's hand with the fierce grip of someone who'd almost lost everything. Their 2 children, a boy of 7 and a girl of 5, were with Jennifer's mother, spared the hospital environment until their father was closer to, being the person they remembered. "Tell me what really happened," Robert said, his voice still weaker than normal, but gaining strength daily. "Dr. Mitchell said you made the diagnosis that everyone else missed, but she didn't give me details. I want to know. I want to understand how close I came to not making it." Marcus felt the familiar uncertainty about how much information to share, how much detail was helpful versus overwhelming. But Robert deserved the truth. It was his life, his body, his near-death experience. "When you came into the emergency room," Marcus began, choosing his words carefully, "you presented with symptoms that looked a lot like acute appendicitis, severe abdominal pain, fever, elevated white blood cell count. It's a common condition, and the initial assessment was reasonable based on the most obvious interpretation of your symptoms." He paused, gathering his thoughts, but there were subtle signs that didn't fit the appendicitis. Pattern: bruising on your abdomen and flank that indicated internal bleeding, a slight yellow tinge to your eyes suggesting liver involvement. The location of your pain was slightly off from typical appendicitis. These details individually could be explained away as variations of normal presentation, but together they pointed towards something else. Necrotizing pancreatitis, a condition where your pancreas becomes severely inflamed and tissue starts dying. Robert listened intently, his engineer's mind clearly working to understand the medical narrative. "But they didn't see what you saw?" he asked. "The other doctors, they thought it was appendicitis." Marcus nodded slowly. "Yes, and that's not entirely their fault. Appendicitis is much more common than hemorrhagic necrotizing pancreatitis. There's a principle in medicine called Occam's razor, the idea that the simplest explanation is usually correct. When you hear hoofbeats, you should think horses, not zebras. Your presentation looked like a horse, appendicitis, but it was actually a zebra, necrotizing pancreatitis. I recognized the signs because my brain processes information differently than most people's. I have autism spectrum disorder, specifically what used to be called Asperger's syndrome. It means I notice details that others filter out, patterns that don't match expectations, subtle inconsistencies that might seem irrelevant until you realize they're the key to the entire puzzle." Jennifer squeezed Robert's hand tighter, tears forming in her eyes as she processed how close they'd come to a very different outcome. "So you fought for him," she said, her voice thick with emotion. "Even when others didn't listen, you kept fighting to make them see what you saw." Marcus shifted uncomfortably, unused to being the center of emotional gratitude. "I did what I thought was right," he said quietly, "but it wasn't easy. The social dynamics in medicine can be complicated, especially for someone like me who doesn't naturally read social cues or navigate hierarchy smoothly." "What does that mean?" Robert asked, genuine curiosity in his expression. "What's it like, having autism and being a doctor?" The question was direct in a way that most people avoided, dancing around the topic with euphemisms and careful language. But Marcus appreciated the straightforwardness, the genuine interest, rather than awkward pity. It means I live in a world that's simultaneously too much and not enough, he said, his words coming more freely than usual. Too much sensory input. The lights are too bright, sounds are too loud, textures and smells overwhelm me constantly. It's like trying to think clearly while standing in the middle of a tornado of information. But it's also not enough social intuition. I don't naturally understand facial expressions, tone of voice, unspoken expectations, all the subtle communication that happens beneath the actual words people say. Conversations are like solving complex puzzles in real time, trying to decode what people mean versus what they're saying. He paused, organizing his thoughts. But in medicine, especially diagnostic medicine, my brain's different wiring becomes an advantage. I see patterns in symptoms that others miss. I remember details with photographic precision. I can hyper-focus on a problem for hours without losing concentration. The same traits that make social situations exhausting make medical problem-solving natural and intuitive. Robert absorbed this explanation with the same focused attention Marcus imagined he brought to construction plans and engineering challenges. So your autism isn't a disability in medicine, he said slowly, working through the concept. It's more like a different operating system that processes the same information in a different way. Marcus felt a smile tug at his lips, the first genuine one in days. That's actually a perfect analogy, he said. Yes, exactly like that. Most doctors run on one operating system, and I run on a different one. Neither is better or worse. They're just different, with different strengths and limitations. The problem is that medicine, like most of society, is designed for the standard operating system. People running different software are expected to adapt, to mask their differences, to function as much like the majority as possible. And when someone's natural processing doesn't fit the expected pattern, they're often seen as deficient rather than different. Jennifer spoke up, her voice gentle but intense. Well, I'm grateful your operating system is different. I'm grateful you see things others miss, because otherwise, she couldn't finish the sentence, emotion choking off her words. The alternative hung unspoken in the air. Otherwise, Robert would have gone to surgery for appendicitis. The wrong diagnosis would have been confirmed too late, the hemorrhagic. Pancreatitis would have overwhelmed his system, and he would have died on the operating table or shortly thereafter. I'm grateful too, Robert said firmly, and I want other people to know what you did, how you saved my life by refusing to give up, even when everyone told you that you were wrong. That takes courage that has nothing to do with medicine and everything to do with character. Marcus felt uncomfortable with the praise, with being positioned as a hero when he'd simply done what seemed medically obvious to him, but he understood what Robert was really saying, that speaking up despite social pressure, that maintaining conviction in the face of dismissal, that was the courageous part, not the diagnostic insight itself. Thank you, Marcus said simply, accepting the gratitude with as much grace as he could manage. I'm just glad you're recovering. You still have a long road ahead. Several more weeks of hospitalization, months of healing after you're discharged, lifestyle changes to protect your pancreas from future inflammation. But you'll get there. You're strong, and you have people who love you supporting the journey. As if on cue, a nurse knocked on the door and entered, carrying a tray of medications for Robert's evening doses. The moment of intimate conversation broke, replaced by the routine mechanics of hospital care. Marcus stood to leave, recognizing that his presence was no longer needed, that Robert and Jennifer deserved privacy to process their experience together. Dr. Chen, Robert called out as Marcus reached the door. Marcus turned back, one hand on the doorframe. Thank you for everything, for seeing me when others looked right past the real problem, for fighting when it would have been easier to stay quiet, for saving my life. Marcus nodded, not trusting his voice to remain steady if he tried to speak. He stepped into the hallway, letting the hospital room door close behind him, and stood for a moment in the fluorescent-lit corridor, collecting himself. The emotional weight of the past 2 weeks crashed over him all at once. The stress of the initial confrontation, the fear that he'd been wrong, the vindication of being proven right, the terror of watching Robert nearly die anyway, the exhausting vigilance of the ICU period, and now this, the profound gratitude of a patient who understood exactly how close he'd come to death. Marcus's hands began their familiar tapping pattern, 3 beats against his thigh, grounding himself in the physical rhythm while his emotions settled back into manageable levels. This was why he'd become a doctor, he realized. Not for the intellectual challenge, though that was certainly part of it, but for the profound privilege of making a difference when it mattered most, of being the person who saw what others missed and refused to let that insight be silenced. 3 months after Robert Callahan's emergency surgery, Marcus stood in the hospital auditorium facing an audience of medical students, residents, and attending physicians gathered for the monthly Morbidity and Mortality Conference, the M&M, where complex cases were presented and dissected to extract lessons that could improve future patient care. Dr. Mitchell had insisted that Marcus be the primary presenter for Robert's case, overriding his protests that he wasn't comfortable with public speaking and that the attention made him anxious. "This is important," she'd said firmly. "Not just the clinical lessons about necrotizing pancreatitis, but the bigger lessons about diagnostic reasoning, about listening to concerns regardless of who raises them, about the value of cognitive diversity in medicine. You need to tell this story." So here he stood, laser pointer in hand, his slides displayed on the large screen behind him, facing the assembled medical professionals with the kind of terror that emergency medical crises never inspired in him. Public speaking hit every one of his vulnerabilities: the need to read social cues in real time, the requirement for smooth verbal delivery, the exposure to judgment and evaluation by dozens of people simultaneously. But he'd prepared obsessively, rehearsing every word, anticipating questions, building his presentation with the same meticulous attention to detail he applied to differential diagnoses. "This is the case of a 42-year-old male who presented to our emergency department with acute abdominal pain, initially diagnosed as appendicitis," Marcus began, his voice steadier than he'd expected, thanks to the prepared script he'd memorized. What followed was a diagnostic journey that nearly cost the patient his life and taught all of us, myself included, important lessons about cognitive biases, communication breakdowns, and the critical importance of attending to diagnostic uncertainty, even when a working diagnosis seems obvious. He clicked through the initial slides, presenting Robert's case systematically: the initial presentation, the vital signs, the physical exam findings, the laboratory values. The audience followed along, many of them nodding as they absorbed information that clearly pointed toward acute appendicitis. Marcus could sense them forming their own diagnostic impressions, going down the same mental pathway that Dr. Mitchell and the trauma team had followed. Then he advanced to the next slide, which highlighted the atypical findings: the bruising patterns, the jaundice, the pain location, the subtle signs that didn't quite fit. "But there were discordant details," Marcus said, his laser pointer circling each finding on the screen. "Cullen's sign, periumbilical ecchymosis; Gray-Turner's sign, flank bruising; mild jaundice; left-sided pain guarding. Individually, these could be explained as variations or secondary findings, but collectively, they suggested a different primary pathology: acute necrotizing pancreatitis with hemorrhagic complications. He clicked to the CT images, showing the scan that had been initially interpreted as appendicitis. The appendix, as you can see here, was actually normal, but the pancreas showed significant inflammation and early necrosis. The free fluid in the abdomen wasn't from appendiceal perforation, it was hemorrhagic pancreatic exudate. A hand went up in the audience. A senior resident from the surgery department, Dr. Chen, in real time, how did you distinguish between appendicitis and pancreatitis when the presentations can overlap significantly? Marcus had anticipated this question, had prepared for it specifically. Pattern recognition combined with attention to details that didn't fit the expected narrative, he said. I think most physicians develop heuristics, mental shortcuts, that allow for rapid diagnosis of common conditions. These heuristics are incredibly valuable and correct the vast majority of the time, but they can also create cognitive anchoring, where we become fixated on an initial diagnosis and unconsciously filter subsequent information to fit that diagnosis, rather than revising our hypothesis based on contradictory evidence. He advanced to the next slide, which showed a flowchart of the diagnostic reasoning process. In this case, the initial presentation triggered the appendicitis heuristic for the attending physician and the trauma team. Once that anchor was set, confirmatory information was weighted more heavily than contradictory information, a cognitive bias called confirmation bias. My different cognitive processing style meant I didn't anchor as strongly on the initial impression. I weighted all the details more evenly, which allowed the contradictory pattern to emerge more clearly in my analysis. Another hand, this time from Dr. Mitchell herself, sitting in the front row. Dr. Chen, can you talk about the communication breakdown that occurred, how the diagnostic disagreement was handled, and what we all can learn from that interaction? Marcus felt his heart rate spike. This was the most difficult part of the presentation, the part where he had to acknowledge the interpersonal conflict and his own struggles with advocacy in the face of authority. He took a breath, gathering courage. This case represents a failure of communication on multiple levels, Marcus said carefully. I identified the correct diagnosis early, but struggled to advocate effectively for my interpretation. Part of that struggle was personal. I have autism spectrum disorder, and assertive confrontation in ambiguous social situations is particularly challenging for me. I second-guessed my conviction because the social dynamics suggested I should defer to the senior physician's experience and authority. He paused, making himself maintain eye contact with the audience, even though every instinct screamed to look away. But part of the failure was systemic. Our medical hierarchy often privileges credentialing and experience over observational accuracy. When a junior physician raises concerns that contradict a senior physician's assessment, the structural power imbalance makes it difficult for those concerns to be heard and taken seriously, regardless of their clinical merit. In this case, Dr. Mitchell ultimately did change course once intraoperative findings contradicted the appendicitis diagnosis, but we lost critical time in that delay, time that significantly increased the patient's mortality risk. The auditorium had gone very quiet, the audience fully engaged with what was essentially a public acknowledgement of medical error and system failure. Dr. Mitchell stood up from her seat, turning to face the audience rather than Marcus. I want to add something here, she said, her voice carrying clearly through the space. Dr. Chen is being diplomatic, but let me be blunt. I made a significant diagnostic error in this case. I anchored on appendicitis and dismissed contrary evidence, including explicit warnings from a colleague who turned out to be completely correct. My error was compounded by allowing biases about Dr. Chen's communication style and his neurodivergent traits to influence how seriously I took his clinical reasoning. She paused, letting her words sink in. This case taught me that cognitive diversity isn't just a nice, abstract concept. It's a clinical asset. Dr. Chen's different neurological wiring allows him to see patterns that my brain, with its more typical processing, filters out as noise. That's not a bug in his system. It's a feature, and our medical culture needs to do better at recognizing and valuing different cognitive styles, at creating space for dissenting opinions regardless of where they come from in the hierarchy, and at building communication systems that allow critical observations to be heard even when they're delivered awkwardly or without traditional markers of authority. The audience erupted in spontaneous applause, a rare occurrence at M&M conferences which typically maintained a more subdued academic atmosphere. Marcus felt overwhelmed by the response, by the public validation from Dr. Mitchell, by the sense that something important was shifting in how this medical community thought about diversity and diagnostic reasoning. He clicked to his final slide, which showed a photograph of Robert Callahan, not from the hospital, but from a follow-up appointment 2 months post-discharge, showing a healthy man smiling at the camera with his wife and children beside him. "Mr. Callahan made a full recovery," Marcus said, his voice thick with emotion he didn't try to hide. "He required 3 months of outpatient care and physical rehabilitation, but his pancreas healed, his strength returned, and he was able to resume his normal life. The outcome was positive ultimately, but it came very close to being a tragedy because of systems and communication failures that we as a medical community need to address." The applause resumed as Marcus concluded his presentation, and for once he didn't feel the usual desperate urge to escape from the social attention. Instead, he felt something different, a sense of purpose, of having contributed something meaningful beyond just this single case, of being part of changing how medicine thought about cognitive diversity and diagnostic humility. 6 months after the night that had nearly cost Robert Callahan his life, Marcus sat in a small cafe near the hospital during his lunch break, reviewing patient charts on his tablet and enjoying a brief respite from the sensory assault of the emergency department. The cafe had become his refuge, a quiet corner where he could decompress and recharge between shifts, where the predictable routine of ordering the same lunch every day provided comfort and structure. He was deep in concentration, analyzing lab trends for a complex case he was following, when a shadow fell across his table. Marcus looked up to find Robert Callahan standing there looking healthy and strong, a genuine smile on his face and a bouquet of flowers in his hand. "Dr. Chen," Robert said warmly, "I was hoping I'd find you here. The nurses said you usually take lunch at this cafe." Marcus felt his usual social awkwardness activate, uncertain about the appropriate response to being sought out during personal time by a former patient. But Robert's expression was so genuinely friendly, so free of the pity or condescension that sometimes accompanied people's interactions with him, that Marcus found himself relaxing. "Robert," Marcus said, gesturing to the empty chair across from him, "you look well. How are you feeling?" Robert sat down, setting the flowers on the table between them. "I feel great, honestly. Back to work, back to normal life, no pain, no complications. It's like the whole thing never happened, except for the scars and the memories." He paused, his expression becoming more serious. "I wanted to see you, to thank you again now that I'm further removed from the crisis and can really appreciate what you did. You saved my life, Dr. Chen, not just through your diagnostic skill, but through your courage to speak up when it would have been easier to stay silent. I've thought about that a lot over the past 6 months, how many other people might have doubted themselves and given in to the social pressure. How unique it was that you trusted your insight enough to fight for it even when everyone was telling you that you were wrong." Marcus felt uncomfortable with the praise, as he always did, but he was learning to accept gratitude more gracefully. "I'm glad you recovered," he said sincerely, "and I'm glad my different way of seeing things proved useful rather than just being a source of social friction." Robert leaned forward, his engineer's mind clearly working through something he wanted to articulate carefully. "I've been reading about autism since I learned you had it," he said, "trying to understand what it means, how it affects you, why it made you see what others missed in my case. And I realized something. We spend so much time in society trying to make everyone fit the same mold, trying to get people who think differently to conform to standard operating procedures. But in doing that, we lose something valuable. We lose the perspective that comes from genuine cognitive diversity, from having people in the room who process information differently and therefore see different patterns and solutions." He paused, gathering his thoughts. "I work in construction, right? And we've learned that structural integrity comes from diversity, different materials with different properties, combined in ways that make the whole stronger than any individual component. Steel and concrete together are stronger than either one alone because they have complementary strengths and weaknesses. I think medicine is the same way. You need doctors with your diagnostic gift seeing patterns, but you also need doctors like Dr. Mitchell with her years of surgical experience and practical wisdom. The system is strongest when both perspectives are valued and integrated. Marcus considered Robert's analogy, finding it more insightful than many academic discussions he'd heard about neurodiversity in professional settings. That's actually a profound observation, Marcus said slowly, but the challenge is that systems naturally gravitate towards standardization and homogeneity. It's easier to train everyone to think the same way, to follow the same protocols, to communicate through the same channels. Accommodating cognitive diversity requires deliberate effort and institutional support. It means creating space for different communication styles, different problem-solving approaches, different ways of interacting with patients and colleagues. Most medical institutions say they value diversity, but operationally, they still expect everyone to conform to neurotypical norms of interaction and hierarchy. Robert nodded, absorbing Marcus's perspective. "So, what changes that?" he asked. "How do we build medical systems that actually leverage cognitive diversity rather than just tolerating it?" Marcus felt a smile tug at his lips. "That's the question Dr. Mitchell and I have been working on," he said. "She's been incredible, actually. After my presentation at the M&M conference, she started pushing for changes in how our department handles diagnostic disagreements and incorporates input from junior physicians. We've implemented a system where any team member, regardless of rank, can formally flag a case for secondary review if they have concerns about the working diagnosis. It's early, but it's already caught 2 cases where the initial assessment was headed in the wrong direction." "That's amazing," Robert said, genuine enthusiasm in his voice. "That's exactly the kind of structural change that makes a difference. Not just acknowledging that diverse perspectives are valuable, but building concrete systems that make it safe and easy for those perspectives to be heard." They sat in comfortable silence for a moment, 2 men from very different backgrounds, connected by a shared experience of crisis and survival. Marcus felt something he rarely experienced, a sense of friendship, of genuine human connection that didn't feel forced or performative. Robert had sought him out not from obligation, but from authentic desire to maintain the relationship that had formed between patient and physician. "These are for you," Robert said, pushing the flowers across the table toward Marcus. "My wife's idea, but I agree with her. You deserve something too. Mark what you did, to remind you that your different way of seeing the world isn't a disability or a deficit. It's a gift. And I'm alive because you trusted that gift enough to fight for me when no one else would." Marcus accepted the flowers, feeling emotion tighten his throat in a way that made speaking difficult. He managed a simple "thank you" that carried more weight than the 2 small words could really convey. As Robert stood to leave, letting Marcus return to his lunch and his patient charts, he paused with one hand on the back of his chair. "One more thing," he said. "I've been telling everyone who'll listen about what happened to me, about how an autistic doctor saved my life by seeing what others missed. I don't know if that's helpful or if it makes you uncomfortable, but I feel like people need to hear these stories. They need to understand that neurodiversity isn't just about accommodation and tolerance. It's about recognizing genuine strengths that the majority population doesn't have. You're not broken, Dr. Chen. You're exactly what medicine needs more of." Then he was gone, leaving Marcus alone with a bouquet of flowers and a profound sense that something fundamental had shifted in how he understood his place in medicine and in the world. For so much of his life, Marcus had viewed his autism as something to be managed, masked, minimized, a collection of deficits and challenges that made normal life exhausting. But Robert was right. In this case, in this context, his different neurological wiring hadn't been a disability at all. It had been exactly what was needed. It had been the difference between life and death. Marcus gathered his tablet and his flowers, preparing to return to the emergency department for the second half of his shift. The ER would be chaos as always. Bright lights, loud sounds, constant interruptions, all the sensory overload and social demands that made every shift exhausting. But he would walk back into that environment with a new understanding of his purpose there, a clearer sense of why the exhaustion was worth it. Because somewhere in the organized chaos chaos of emergency medicine, there would be another patient like Robert Callahan, another case where the obvious diagnosis was wrong, where subtle details held the key to the correct answer, where someone needed a physician who saw patterns that others filtered out as noise. And Marcus would be there, his different operating system processing information in ways that would seem strange and awkward until the moment when it proved essential. He thought about Dr. Mitchell's evolution from skeptical supervisor to genuine advocate, about the changes being implemented in their department, about Robert's structural integrity analogy, and the idea that strength came from combining different materials with complementary properties. Medicine was learning slowly that cognitive diversity wasn't a problem to be solved, but a resource to be cultivated. And Marcus, with his autism that made social situations exhausting but medical mysteries intuitive, was part of that future, not despite his differences, but because of them. Robert Callahan walked out of that hospital alive because one doctor refused to stay silent, refused to doubt what his unique mind could see. This is more than a medical story. It's a reminder that being different isn't a weakness. It's often exactly the strength the world needs most. If this story moved you, hit that like button, drop a comment telling me what you think about doctors who see the world differently, and subscribe because we're just getting started with stories that will challenge everything you think you know about medicine, disability, and what it really means to be a hero. Thank you for watching, and remember, sometimes the person everyone underestimates is the only one who can save the day.